Welcome to the Medical Chalk Talks podcast. I'll be your host, Ever Arias. I am currently a second year internal medicine resident, finishing my training and then going on to pulmonary critical care fellowship. Before I start talking about the topic at hand, the COVID-19 introduction primer, I want to briefly discuss why this podcast is very important during this time. I started this podcast out of a love for medical teaching, out of a love for medicine. And it was difficult for me to find resources that I felt were doing an appropriate job to be able to assimilate all the information. So my goal is really to empower you to seek out information for yourself, but also to have these discussions. And this podcast is tailored to everybody who loves medicine, but the information will be tailored specifically to medical students, residents, nurses, PAs, all the healthcare providers on the front lines. So with that being said, join me today discussing COVID-19, an introduction primer. I want to just kind of go over the contents of this discussion so you understand what you'll have. So essentially, I'll be discussing specifically the introduction of the COVID-19, how it started, the physiology, diagnosis, presentations, including labs, imaging, and any clinical situations that we need to be aware of in terms of when we should suspect COVID-19 patients and what appropriate precautions the data shows. And then finishing the topic with potential treatments. I will not discuss any of these topics in full detail, but I'll give you a good framework to start with. And then the following podcast that I'll have will give you a more detailed view of those specific topics. So let's start with the COVID-19. So what exactly is COVID-19? A lot of questions. Obviously, we're not going to call this Wuhan virus. We're not going to call this China virus. We're going to go by its nomenclature, scientific nomenclature, as the SARS-CoV-2, which is a new coronavirus. We had SARS. There's multiple coronaviruses, but this is a SARS type. And so the reason why it's similar is because it's also coronavirus is a specific species of a virus. And then the other thing we need to look at is CoV-2 is a positive sense RNA, meaning that that's what makes it a little bit more deadly is because these specific viruses are able to go into the host. And typically for some viruses that are negative sense, they need an RNA polymerase to change them to positive sense. And that's a good thing for us because we have a different way of attacking, of stopping the machinery, potentially having RNase polymerase inhibitor. For this virus, they don't have their positive sense, so they don't need an RNA polymerase to change. So that's something that I think a lot of people are not talking about. So that's something that is potentially also causing harder for us to come up with medications. Okay, so moving on to the next section, the physiology behind the COVID-19. So there's been a lot of literature showing that viruses have a spike protein that binds to the receptors called ACE2. And with this receptor, something you need to know about is there's a lot of confusion right now currently because this receptor is called the angiotensin converting enzyme 2. And patients who are hypertensive take certain medications like ACE or ARBs. And really, right at this point, the effect of ACE ARB with patients taking those medications in terms of having an increased amount of receptors, so having more issues with the virus itself, we don't really know. It's just a theoretical risk. And there's no strong recommendations to discontinue taking this medication. So I just wanted to let you guys know before I continue this talk about that. But in terms of the interaction between the spike protein, the viral spike protein, and the ACE2 receptors, so the way that this works, the virus itself cannot replicate by itself. It needs to attack a host. And the way that it attacks this host is by essentially having the key to open up its doorway. And that's kind of what the viral spike protein is. It's almost like a key, lock and key mechanism with the ligand to be able to bind and get into our cells. The ACE2 receptors are found almost everywhere. As far as I know, it's found in type 2 pneumocytes in the lungs. It's found in myocytes in the heart. It's also found in the vasculature, vessels, and some other organs. But beyond that, it really, the biggest thing is what happens afterwards, after it binds. So the way, I won't detail it too much here. That's a different topic that I'll discuss. But in general, it causes a consumption of the virus itself, called endocytosis, and through many different pathways, it's able to get out of that vesicle and eventually be able to replicate itself. And those medications that we will talk about briefly is asking, how can we stop certain phases, the pre-viral entry and post-viral entry pathway. So with that, I'll let that sit a little bit, and we'll discuss this at a different episode. But the next step that I would like to discuss now is, so what does this all mean? Why are you telling me this, and why do I care? You would want to care because in the end, that's the reason why a lot of patients are dying, is because they are having something called a cytokine storm, meaning there's such a huge inflammatory response from this virus that it is causing patients to go into acute respiratory distress syndrome, causing them to have complete inflammation of their lungs and eventually get intubated and die. It's all from this etiology. It's all from this cause. And ultimately, it's from this uncontrolled inflammatory cycle that we are trying to find ways to control. So the next step is knowing how to detect it. How do I, as a clinician, have my kind of radar, my screening tool? So that's kind of the next thing that I want to discuss is there are actual CDC screening criteria for suspected COVID-19 patients. And briefly, really just kind of putting it all together, it's really anyone who has a fever, anyone who's coming in with signs or symptoms of lower respiratory illness, cough, shortness of breath, especially, and who have been in contact with anybody who have had it confirmed. At the end of the day, is really anyone who has a cough, who has fevers, myalgias, upper respiratory, dyspnea. So CDC is recommending to screen basically everybody. And that's where the issue comes in, is how do we screen everybody when we don't have the capability of screening? So that's why rapid PCR testing is being tested now, and hopefully we have a better access to those certain interventions or treatment modalities. So the other step in terms of diagnosis presentation is, do patients present with certain labs that we know of in terms of data, in terms of the literature? And the answer is no. A lot of these patients could present with normal labs, and some of them, typically, the one that I've seen that's more common is leukopenia and lymphopenia. Patients could have lymphopenia, about, I'm not sure exactly how, but it's closer to 60 to 80 percent of patients present with that. And BNP could be elevated, so you have a creatinine BUN. I'm not sure if it's a trend to which specifically. It's just an AKI that you would see typically. In terms of LFTs, you would have those that are elevated. D-dimer and CRP, and of course, will be elevated. These are typically elevated in any pretty predominant inflammatory state. Interleukin 6, and that's something that we'll talk about later. But that's also been being seen as something that's kind of connected to the cytokine storm. And we have medications to kind of combat that. And you see that that's elevated. Ferritin is also elevated. And then something that's really interesting is procal is down typically. And when it is elevated at a pretty significant level, and the patient has symptoms of possible pneumonia, that's a pretty high likely pretest probability that patients could have a super imposing pneumonia on top of that. In terms of imaging, there's really something you need to know, is that imaging is not diagnostic. Some patients could have negative imaging, including chest X-ray and CT, but if they have still clinical suspicion, you would still want to rule them out. So chest X-ray has hazy bilateral peripheral opacities often. CT, the most common, is ground glass opacities that we've been seeing. Rarely they are unilateral. Typically it's bilateral. If you do a bedside ultrasound, you could see numerous B lines, pleural line thickening, consolidations. Almost looks like a pretty bad pneumonia. So when you have patients coming into the ED, what you want to do is obviously isolate them at hand, and use appropriate precautions. And that's something that we're using now. Is kind of everybody who's coming in with any of those above symptoms. We are being very cautious in how we see the patients. So what we recommend in the correct sequence is standard. You do standard precautions, obviously, and then you do contact and you're airborne, depending on the procedures. So something we need to know also, and so this is all for the healthcare providers, is we want to make sure that we're not aerolizing this virus. So try to avoid actually, very strong recommendation to avoid any high risk aerosolization procedures that include really anything that like BiPAP, high flow nasal cannula, bag valve mask, nebulizer treatments. And if you're intubating, make sure you are using the appropriate the PPEs. So that's something that we really need to be aware of. Is we need to protect the healthcare workers, because if you're sick, then you won't be able to help the thousands of patients that you would be helping otherwise. So again, do not avoid nebulized medications and suspected COVID treatments. Do not give them DUNAP treatments. Avoid BiPAP, CPAP. Obviously, there is certain caveat to that. Obviously, if patients have asthma or COPD and that's really what's going on, then you want to kind of use your clinical judgment in terms of using nebulized medications or not. You obviously do not want to hold any life-saving interventions. And like, again, I want to reiterate, this information that I'm providing is just my opinion. Please make your own make your own decisions. Consult with your own senior residents, senior attendings when applying this clinical information to your patients. With that being said, let's move on. In terms of treatments, so currently treatments are really exciting topic at hand now. There's many different types of treatments, and I won't go into every little detail on this videos, but I wanted to kind of just gonna give you again the bird's eye view of everything. So what do we know right now? So the ones that we've tested so far are lopinavir, ritonavir, interferon beta, remdesivir, hydroxychloroquine with azithromycin, and tocilizumab. So just letting you know, lopinavir, ritonavir, I'll go over this big details on that. Um, that's available, but recent negative randomized clinical trials have showed it to not be beneficial. So we're not really using it as much or at all. In terms of the other remdesivir, that's not approved yet. It was usually used for patients with compassionate care, meaning they were very close to dying. But there are really robust randomized controlled trials now that are currently investigating the efficacy of this medication. Hydrochloroquine with azithromycin, it is I know it's been reaching a lot of media attention, but it was done on a small non-randomized control study. It did show that it reduced viral loads within, I believe, 28 days. But just letting you know, it's important for us to be aware that this study still needs more work. But obviously, if patients have nothing else, then at that point, maybe this could be appropriate. But definitely not appropriate for family members or for anyone outside of the hospital to be taking this medication as prophylaxis, because we have seen many fatalities from this, because it causes your QT to be prolonged, and that could go into torsades and eventually go into ventricular fibrillation. So that's something we need to be considering. So do not take this at home without any medical prescription. So the next one is tocilizumab, and that's still under investigation. It's still ongoing, but really, there's a lot of medications right now that we're still investigating, and we have to be aware that we need to speed up this process. Obviously, so that's all I have for today's episode. Obviously, I wanted to keep this very broad view. I'll go into specific details later on. I really hope you enjoyed this podcast, and I urge you to continue listening to more future episodes. The next episode, which will be posted later on today, will be a crash course into the ICU. So what's going to happen is a lot of these patients are going to the ICU. I want to make sure that you are appropriately aware of what to do, how to manage vents, what is a ventilator even, how to manage an ABG, and knowing about acute respiratory distress syndrome and the management will be very useful. Again, all this information will be I want to give you as much information as I can, but I cannot do this alone without your help. So please give me feedback if you're learning. I want to know about it. So please drop feedback as much as you can so that I could get better and then so that we could all learn together. So with that being said, thank you to listening to the Medical Chalk Talks. I'll be your host again in the next episode. And if you want to follow me on Instagram, follow me at everariasmd, and I'll talk to you there. Take care.